Welcome everyone. We really appreciate you joining us. Sorry for the slight delay, but this is a recording and a presentation that's sort of in conjunction with one we've previously done. I'm Dr. Lindley Wall, part of the hand team at Washington University in St. Louis, and I'm joined by my partner. And we're going to be talking about sort of the other numbness and tingling in your hand, which goes along with carpal tunnel, but is a little bit different. So David, you want to introduce yourself?
Sure. Thanks, Lindley. So my name is Dr. David Brogan. I'm another orthopedic hand and upper extremity surgeon at Washington University. I specialize in peripheral nerve injuries and compressions and microsurgery. So yeah, as you mentioned, Lindley, this is a continuation of a session that we had a few weeks ago on carpal tunnel and kind of hand numbness and tingling and why nerves would be irritated and what could cause hand numbness and tingling. And at that session, we talked a lot about carpal tunnel syndrome, but today, hopefully talk a little bit more about some of the other things that can cause issues, such as cubital tunnel syndrome. So Lindley, why don't you start us off? How is cubital tunnel syndrome, which is probably something that people have heard less about? How is it different than carpal tunnel syndrome? And how do you explain that to patients when you see them in the office?
Yeah, absolutely. So I think everyone pretty much knows carpal tunnel, and what we talked about last time was typically carpal tunnel syndrome. People present with some numbness and tingling in their thumb, their index, and their middle finger, sometimes a little bit on their ring finger. But if someone comes in and they tell me that they feel numbness and tingling in their small finger and then that small finger side of their ring finger, that's much more common to be a cubital tunnel. And so cubital tunnel is the tunnel itself that we're talking about is up here at the elbow. So it's the funny bone nerve is what I tell people. So if you bang your funny bone, that is your cubital tunnel area. And that is the ulnar nerve, which is different than carpal tunnel, which is the median nerve. And so people usually come in saying my small finger, my ring finger go numb, they get tingly. Oftentimes, kind of like with carpal tunnel, happens at night. For me, most people don't complain as much about pain as they do with carpal tunnel, but a lot of numbness and tingling in their fingers. They have to kind of shake their arm to make it kind of wake up. But it's really sort of that inside elbow, sometimes painful, and then numbness and tingling. Weakness is also something that can come up. The hand can feel weak because just like with the median nerve, the ulnar nerve gives you feeling to these fingers, but also gives you strength to the little muscles in the hand. And so we try not to forget that, but it can make your hand feel, it's like harder to squeeze things and it's harder to do things. So what are some of the activities that you have people complain about to you? I mean, the nighttime stuff, but then there's some, do you have any activities people complain about?
Yeah, so it's interesting because sometimes the activities that cause carpal tunnel and cubital tunnel can be similar, and so it can be a little difficult to distinguish. But the classic things a lot of people will talk about are activities that involve bending the elbow, because we know that one of the things that irritates the ulnar nerve in the cubital tunnel, it's similar, but in some ways a little different than what happens in the carpal tunnel. The carpal tunnel is mainly pressure and compression of the nerve. In cubital tunnel, there is a little ligament that can compress the nerve as well. The other thing that can happen is that as you bend your elbow, it puts some tension on the nerve. It kind of pulls on that nerve, and that nerve makes a sharp turn around that prominent bone that you mentioned, the medial epicondyle. And so some folks, when they find that they bend their elbow, that makes things worse, probably because of tension and also compression as well. And so things that you typically do when you're bending your elbow, such as talking on the phone, is a really common one. People say, I put it on speakerphone now, or I use my other hand to talk on the phone as a result. Sometimes pain at night. Sometimes people who do weightlifting and have really strong triceps, as the triceps muscle gets bigger, that seems to bother them. So that's one of the ways that we treat it early on, is try and tell folks, well, it sounds simple and silly, but seems to be effective to just try and keep your elbows straight at night. And sometimes you can just consciously do it and try and lay in a different way. Is there anything that you typically do to try and help people with initial management of it in terms of keeping it straight at night? Do you use any splints or anything like that, Lindley?
Yeah, good. I do. Therapy can make braces, but I'll tell you this, while that will keep your elbows straight for sure, those are typically hot and sweaty. And so I usually don't have much, people really don't like that. So what I like to do is I tell people to go to Walmart or go to a sports store. I have no disclosures, just any store that sells braces, and like a volleyball elbow brace. And I have them take that padded part that's supposed to go behind your elbow and slide it to the front. I like that because it's something you don't have to, you just slide it on. It doesn't fall off in the middle of the night, but it really, what it does, it's just like David said, it keeps your elbow out instead of being squished this way. And you don't need your elbow straight, but right, just blocking the flexion so that your nerve has, gets the most blood flow is kind of how I think about it. Less compression. I also think altering how people do things during the day, like typing. A lot of times when I'm on my computer, I have my elbows bent up. And so stretching your elbows out so that they're more extended, even while you're prolonged working at your desk, can be very helpful. Yeah.
Same thing with, oh, go ahead.
Yeah, no, go ahead.
I would say same thing with driving. Sometimes I find that folks talk about if they're driving and they've got kind of their hands on their knees sort of position, that will tend to make it get worse. And they'll describe kind of an aching pain in the elbow. If they have pain, it's usually pain more in the inside of the elbow, as you mentioned, not so much in the wrist. And sometimes it's better for folks that they keep kind of both arms more straight when they drive, and that seems to be less irritating to them as well. And the other thing I found is that it's tough sometimes because I think I probably have a little bit of cubital tunnel too, and I know which fingers should be involved, but sometimes it seems like all of them are involved, and so I think it's difficult. You know, there's what the textbook says, and then kind of what happens in real life, and so just because it doesn't exactly follow the small finger or whatever, I think it's tough to tease that out. But I agree with you. Usually, if the small finger is involved, it tends to be more likely to be cubital tunnel. If it's the thumb involved, it tends to be more likely to be carpal tunnel, or it's maybe something in the neck, as we talked about last time. So.
What do you do for your initial treatment besides splinting? Do you think there's any role? Can someone get an injection to make this better? Do you like any type of medications? What do you use?
Yeah. So unfortunately, there's not a lot of great things I think are super effective with cubital tunnel. Splinting and carpal tunnel seem to be well tolerated and fairly effective as a first-line intervention. Splinting and cubital tunnel, I think it's tougher for people to do sometimes, and so they may not be as compliant and use the splints as much as might help them. Sometimes even occasionally I'll refer people to occupational therapy, and they'll do these kind of nerve gliding exercises to kind of loosen up the nerve and decrease some of the tethering. And I think there's some benefit to that. Injections, I will occasionally do that. It's not one of my favorite things. It's kind of a tender area, and I don't like sticking the needle in there because there's not much extra space. So if I need to do that, I'll sometimes get one of my partners to do that with an ultrasound to help guide it. But occasionally medications like gabapentin, if they're having a lot of nerve pain and kind of zingers, that can help. But usually it's trying to change how they position themselves, and then eventually surgery. Any other things that you do that I haven't thought of, Lindley?
Yeah, I think sometimes anti-inflammatories can be helpful. So a little bit of inflammation can kind of worsen things, but I do agree the splints is definitely my go-to. Some people, if they have sort of an acute flare-up, sometimes a steroid dose pack can just calm things down if it's just been going on a short period. But yeah, I don't do injections. I don't really, I haven't seen much literature to show that cures people. I think sometimes it's helpful, trying to figure out where the main problem is.
Right.
And the other thing that, you mentioned ultrasound that I was thinking about, there's a different group of people who have pain and some popping and then finger numbness that kind of comes with that. And so there's some people whose nerve, like you said, that bone, that medial epicondyle, so that bony prominence, where their nerve actually will pop back and forth over that bone. And that can make it really irritable. And so I see that a little bit more commonly where people are symptomatic and they have pain or they have popping in my younger population. So the nerve is just unstable, so it stays irritated. And so unfortunately for that, even splinting doesn't really help, and surgery works really well to stabilize the nerve. So
sure. If somebody finds that they have that nerve just popping on its own, it doesn't bother them, what do you tell them about that? Do they need to have anything done?
Leave it alone. They're lucky. Yeah. And it doesn't mean that it will bother them, but it's just, if it gets flared up, it can be one of the causes. So.
Right. The nerve gets irritated.
Right.
And
right.
Yeah, I agree that instability, it also changes a little bit what we do in surgery at times. But I agree that that can certainly cause people trouble. I guess that leads us to the next point in terms of how do you diagnose it? If they have some classic symptoms and the nerve popping, that seems somewhat straightforward, but what other tests do you order for somebody who comes in and you're suspicious of this?
Yeah, just like we kind of talked with the carpal tunnel, there's no x-ray for this. I don't get an ultra, I don't get an MRI, but I really like nerve studies for this. It shows us if there's compression of the nerve. If it shows us how fast the nerve sends its signal from the brain down to the hand. And so I do like getting that information. And then we also here frequently complement the nerve study with an ultrasound of the nerve, and that can show you if there's compression or if there's some swelling of the nerve. So I like doing those together. I think that gives me a lot of information. But I would say there's a good number of people, more so with this nerve than with carpal tunnel, where sometimes that nerve study is fine, which means the nerve is healthy, it's conducting, but it still could be causing problems. What do you like nerve studies? Do you use those?
I do. I like it because it helps reinforce that we're kind of barking up the right tree, and that and sometimes helps us tease out cubital versus carpal tunnel syndrome as to which one's causing more of the symptoms, along with the physical examination. But yeah, I think it's interesting from a hand surgery standpoint. We see a lot of this where the nerve studies are somewhat accurate, and they're really helpful for carpal tunnel syndrome, and they're somewhat helpful for cubital tunnel. But there's definitely a proportion of people who have classic symptoms. You get the nerve study and it's stone cold normal. And so then it's great because you say, well, your nerve looks great, congratulations. And then it's somewhat disappointing because it's, well, so what's wrong with me? And
Right.
that's obviously a frustrating thing, but it doesn't necessarily mean that the nerve is happy and totally fine. I
Right.
just tell folks that it's kind of, it's the nerve looks good enough and enough of it is working to fool the nerve study, basically.
Right.
And so I think that the ultrasound is very helpful in those situations, because what we know is that as that nerve is more and more irritated and compressed, it reacts with swelling, and that swelling makes the nerve get bigger. And so that's sometimes an early sign, even if the nerve is functioning well, but it's just painful and irritable. They'll see what we call the increased cross-sectional area, or just basically it's a wider nerve. And those folks, I tell them, look, your nerve is working, that's great, but you certainly have a reason to have pain. And so it gives us a little bit more time. I don't feel as much of an urgency to do surgery, because I'm not worried that the nerve is being choked and damaged. But it's certainly, if they don't get better with some of the stuff that we've already talked about, it seems to be a pretty reliable indicator that those folks are going to do better with surgery. And those people are often the happiest because their nerve kind of bounces right back because they don't have that intrinsic damage, basically.
Yeah.
So,
I think
go ahead.
that's a good point about the severity of injury to the nerve, that compression over time. We do know that, more the longer nerve is compressed, the less well it will do. So if you're starting to see these changes where the nerve study is showing us that some of the sensation in the fingers or some of the muscles are starting to atrophy, we know that the ulnar nerve doesn't always do as well, recovering from that. So I think that's something people should consider. But if the nerve studies are showing it's sending a good signal, the hand is working well, that means a healthier nerve. So
I think you're right. Just as we talked about before, in terms of being reliable, in terms of the surgery is good for relieving pain, but getting back normal function is harder. And that's certainly true in carpal tunnel. It's even more true, I think, in cubital tunnel, that it seems to be able to relieve the zinging electrical shocks that people are bothered by. But when you have people who come in and those tiny hand muscles that you described, when those are already atrophied and wasted away because they haven't had that nerve signal getting to it for so long, it's very difficult for the body to recover those. The nerve has to heal from all the way up in the elbow all the way down to the hand, and nerves heal very slowly. And the older we are, the slower they heal. And so that's a challenge. I think that people tend to do better if they have kind of an earlier, if this is addressed earlier, rather than the really late ones are challenged, to say the least.
yeah, I do say in those cases, as you're talking about, my goal with surgery is never to get someone back to before the compression, but to give the nerve sort of the best chance not to get worse
Sure.
and potentially feel better. So I think sometimes the nerve is it's too sick, as you had kind of mentioned before. It was too sick to actually fully recover, but at least people will feel better. And that's my goal. So, yeah.
Sure. So if you've tried everything else, it doesn't, haven't had success with that, the symptoms and the testing are all really pointing to cubital tunnel. And you've come to the decision that surgery is kind of the right thing, and the patient is ready for surgery. What are you telling about the surgery? What does the surgery entail for you? And then what's the recovery like?
Yeah, so for me, surgery is outpatient, and what I usually say is, my goal with surgery is to take the pressure off the nerve. And as you'd kind of mentioned, sometimes that's not enough. And so I start with that. So if we have a nerve, and it's not one of those that's the popping nerve, but my goal is to take the pressure off sort of on the inside part of the elbow right here. And then I always reassess, and I tell everyone before surgery that we make a small incision, we take the pressure off the nerve, take that band off that you were mentioning, and then move the elbow through range of motion. And it could be sometimes when you take the pressure off, the nerve wants to pop over that little bump, that little bone on the inside of the elbow. And I would tell you, no one would be happy with a nerve that is released and then starts popping. So if that's the case, I move it to the front of the elbow. And that puts it in a nice healthy bed. In the front, it doesn't pop, it's stable, and there's no pressure on it. And so that's always my goal. People who are popping beforehand, they get moved immediately. So there's a lot of, as you know for sure, there's a lot of different ways to put the nerve in the front. There's different techniques, sort of just in the muscle, under the muscle, just under the skin. There's a lot of options. Some people remove part of that little bone. I think there's no good evidence right now, which is better than others. And so I think we all, as surgeons, have our own biases of what we like based on how our patients have done. So I don't know if you, particularly with your approach, what are your thoughts, and what do you like to do?
Yeah, same thing. That if somebody has relatively milder symptoms and no evidence of the nerve flipping back and forth, I'll just do the decompression. If they have pretty advanced symptoms, then I'll tend to move the nerve, just because my thought is I want to give them the best chance at having the nerve recover, and that's kind of my ultimate surgery for them. But same thing, in surgery, we'll check it and see. If it's unstable, we move it ahead or move it over it. I use a little bit of tissue over the muscle to make a sling. I think you do it slightly differently, but in a very similar manner. And I think that nobody's ever shown that there's any difference in how we do those. So one thing that we do occasionally is, or at least that I do occasionally, and I'm curious if you do as well, or your thoughts on it. Sometimes for people who have lost a lot of muscle and the nerve looks really, really damaged at the elbow, those folks are pretty weak in their hands. And if we see that on our examination, if we see that on our nerve studies, we sometimes will do a distal nerve transfer. And what that means is that we take kind of a spare nerve that goes to a muscle that's not that important, closer to the wrist, and we'll move that over, and it's kind of like hot wiring people, put a little bit of extra juice closer to the hand. And I've had some patients really had some good success with that, because it helps basically cheat by avoiding all that time that the nerve has to recover up to here. And then we get good, healthy new nerve growing in closer to the hand. And that's a little bit more controversial, I'd say. I don't think everybody does that. Do you do that? I'm curious.
I have a certain group of patients that I would consider that for the, usually I do that in more the traumatic injuries. So the nerves that have been cut.
Yeah.
And I have done it and considered, but in a much smaller number, probably a little, with people who have some people come in and say, my hand was normal 6 weeks ago. They come in now, for some reason, the little muscles have disappeared. They have a lot of atrophy, weakness, and constant numbness. So it's very acute. So it's happened very, very quickly. Sure. And those are people who I think are good candidates for doing that transfer at the same time. And I like that surgery. It's a fun surgery. It does well. But I think the person that you pick has to be a very specific patient. So.
Completely agree. Yeah. And we have a question, I think, as well. Yeah. And the question is, have you noticed an increase in cubital tunnel needing surgery because of cell phone use? So I would say that I don't know if cell phones have been so common in the last kind of 10 to 15 years, which has been most of my practice. I'm not sure I could compare it to, say, the 90s. But a lot of people who come in complain of when they're talking on their cell phones, for sure. I think there's some association with that. How about you, Lindley?
I think that I don't know if I've seen it globally enough, but just to think about it, I think phone, it would be worse, but I think getting down to the texting, I think it's that, where people are spending a lot more time. I've seen it more commonly. They'll complain about it where they're texting, but they're holding their screen kind of close.
Sure.
So sort of like typing, I tell them to, stretch those elbows out so it's not bothering them as much. But
yeah, great.
Yeah.
Excellent. All
Yeah.
right. I think we got another last minute or two. Any final thoughts on cubital tunnel syndrome?
Yeah, I think it's one of those things I think it's a good thing to be evaluated for if you're having issues. I recommend, we don't want nerves to get too sick, and there's definitely ways we can intervene. I do think seeing your local hand surgeon or seeing us, and we're always happy to see people, just to kind of, as you said, sort of pick out the, carpal tunnel versus the cubital tunnel and try to make sure we're addressing the right thing, because a wrist brace won't necessarily make, the elbow better. So sometimes it's good to be evaluated.
I think that's a great way to end. And Lindley, thanks for your time. And thank you to everybody else for tuning in. And we'll have some more of these Facebook Live sessions with some of our other partners covering various topics. We hope you enjoy them, and we're always happy to see you in our clinic if we can be of help. So thanks so much.
Thank you all.